Yeah. Yeah.
right?
Yeah.
So we were doing the pathology. We started with the pathology, right? And we discussed the first few topics like congenital heart disease, the right to left shunt, and the left to
Yes.
right shunt. Remember, right?
Yes.
I discussed till atrial septal defect, and we stopped at the atrial septal defect. If I remember, isn't that?
Yeah, we didn't complete the atrial, so we started with atrial, but we didn't finish it.
Okay. Yeah. The important thing that I told you about atrial septal defect is that the types. Okay, it has two types. The first is the septum primum defect, and the other one is the septum secundum defect. Okay, where there is a
Okay.
third, and although it's not a part of the atrial septal defect itself, but it presents like that. It's called patent foramen ovale, right?
Mm-hmm.
Other than these things, the atrial septal defect also has got the concept of splitting. The splitting will be of fixed type, right?
Yeah.
Right, remember the atrial septal defect is associated with the first thing, the diabetic mother, as well as the alcoholic mother, right, as well as the Down syndrome. So it's associated with
Correct.
all the it has got a problem with the neural crest actually. Now say this thing on the side. Oxygen saturation increase in the right atrium, right ventricle, pulmonary artery may lead to paradoxical emboli associated with down. What are you getting from this? The first para. Increase in RA, RB, pulmonary artery. What do you mean by that?
I'm just saying that the oxygen demand increases in right atrium, right ventricle. Um, well, because you're mixing the blood now, so I'm guessing it's more oxygenated since you're
Very
going back.
Yeah, because the left atrium has oxygen in the blood, right? And because of the left to right shunt, the ASD, right, the oxygen blood is now going into the right atrium, which increases the saturation in the right atrial oxygenated blood. Okay,
Yes.
and obviously this the increased oxygenated blood will obviously will go from the right atrium into the right ventricle. So obviously the increased saturation will be
Mm-hmm.
seen in the right atrium, ventricle, and the pulmonary artery. This is what it means. Okay, what do you mean by paradoxical emboli? I
Yeah.
think I have explained it previously as well.
Yeah, because now the paradoxal emboli, you know how we said like if we have it like say thrombosis in the veins, it's gonna travel all the way towards the heart, and now because there's a shunt there, you can easily go from the right side to the left side. So that's why it can
Very
lead to paradoxal emboli.
Yeah, I mean the venous emboli can go to the arterial circulation because of the presence of ASB.
Because it cannot go before, but because of the shunt, it can.
Yes. Okay.
Yeah.
Before this, they cannot go. They will remain in the venous system. I mean that any vein, the thrombus or emboli arise, they will go to your right heart, and then they will go to the pulmonary veins. That's it. They cannot go beyond your pulmonary vessels. Okay.
Correct.
They can never get an access to the left heart. Only
Yes.
in cases where there is atrial defect presence, or where there is foramen ovale present, the embolus can get access to your left heart, and then it can go to any artery, and it can cause acute mesenteric ischemia, a stroke, or whatever presentation according to the artery. Okay, so this was all
True.
about atrial defect. Any question?
No.
Okay, very good. Then comes your third one, the patent ductus arteriosus. First of all, you need to understand that where this ductus arteriosus is present in the embryonic life and what was the function of it. Can you recall where it is present, the ductus arteriosus?
Ductal arteriosus is the duct that is located between the aorta and your oh my god, it's the one. It's between the aorta and I believe the left atrium.
The left atrium, how? I mean, let's make the same heart that we got,
No, aorta. It's I know it's between the two. It's I'm thinking aorta. Hold on.
Trunk.
I know it's between.
Here, look at the location. This is your ductus arteriosus.
Oh, so it's between the pulmonary trunk and the aorta. Okay. Okay.
Simple. I love this diagram. Why? Because it's very easy. Here is your
Yeah.
ASD, here is your ASD, and this is your
Yeah.
ductus
Ductus
arteriosus.
arterius. Yeah.
Okay, connects the two ducts. Okay, I mean the pulmonary trunk and the aorta. So it is called ductus arteriosus. Now understand the thing. In the embryonic life or in the fetal life, remember the lungs are collapsed. Remember?
Yeah.
So this thing is like this. There is a block in front of the pulmonary artery because the pulmonary vasculature is totally collapsed. They are not patent. So it means that right heart after load is too much, right? So in embryonic and fetal life, the pressures in the right heart are more than the left. Isn't that? Huh? Hello? Hello? Are you here? Can you hear me?
Yeah, yeah. Hello, I can hear you.
Okay, okay.
Hello.
Yeah, now I can hear you. So
I don't know
understand.
what happened.
So understand. So because of the presence of these, collapsed vessel in the pulmonary circulation, the pressures in the right heart in the embryonic and fetal life are more than the left, right? Now,
Yes.
yeah, the nature has given this shunt in the fetal life because you know why? Because when the fetal vessels, remember the cardinal veins, the veins that are not yet developed, when they drain into your right atrium, the blood, okay, this blood will obviously go towards your right ventricle, isn't that?
Mm-hmm.
And because there is a foramen ovale as well, the blood, some part of the blood will also go to your left atrium because of the foramen ovale. Make sense?
Yeah.
Right?
Mm-hmm.
Now, the blood will go from the left atrium to the left ventricle and then to the aorta simply. On the other hand, the blood which is coming in the right atria, part of it will also go to the right ventricle, right? Now, this
Yes.
tries to go through the pulmonary valve into the pulmonary artery. But because the veins are collapsed, the vessel in the pulmonary system are totally collapsed, right? And the pressures in the right heart and pulmonary artery are more than the aorta and the left ventricle. So this shunt will send the blood from right to left direction. I mean, from right heart, the right side is pulmonary artery to your left aorta. It's a right to
You're
left.
talking about the embryonic life, correct? Right?
Yeah, I'm talking
Okay.
about the fetal and embryonic life. So the
Yeah,
use
okay.
of this is our physiology. Okay, so the
Yeah.
presence of ductus arteriosus is physiologically helpful for us. Okay, its presence shunts the blood from the pulmonary artery towards the aorta. Otherwise, the blood can never go to that side. Okay, because of the presence of this shunt, the blood from the pulmonary artery can easily go to the aorta. Because foramen ovale is a very small opening. Okay, the whole 5
Mm-hmm.
blood cannot go from that opening, right? You need something else. That something else is
True.
actually called ductus arteriosus. Okay, it's a physiological shunt present in a fetal life, right?
Yes.
Now, you can ask me now, then where is oxygenation taking place? Because the lungs are collapsed, no blood is going towards the lungs, and where is the concept of oxygenation then? The answer is that oxygenated blood is coming into the fetus from the placenta, right? Maternal vessels. The
Yeah,
mother,
it's
yeah,
exactly.
and the mother is giving its own oxygenated blood via the placenta and via the umbilical veins through the vessels of the fetus, right? And then it is going to your right atrium.
Yeah, that's true.
Yeah, and this is also bypassing the liver, okay, and it is directly going into an inferior
Mm-hmm.
vena cava. And there is one more shunt, the ductus venosus. The
Yes.
ductus venosus bypasses the liver actually, and it then sends the oxygenated blood to the inferior vena cava directly. Okay,
True.
otherwise the liver will consume all the oxygen. So, in
Yes.
order to bypass the liver, the umbilical vein has one more shunt, that which is called ductus venosus. Remember, the shunt here is called ductus venosus near the liver, and the shunt between your pulmonary artery and aorta is called ductus arteriosus.
Mm-hmm.
Right? So this is your
Yes.
concept. This is your concept. Remember, oxygenation is not taking place in the fetal and embryonic life. Oxygenated blood is coming from the mother side, from the maternal side, isn't it?
Yes.
Right? This is a very simple and clear and easy concept about the ductus arteriosus. Now, yes, we need it in the fetal life, but if it is not closed after the fetal life, now understand the concept first, and when and how it will be closed in the fetal life. Now, when you are born, okay, so the pulmonary vessels will immediately open up, right?
Yeah. Yeah.
These vessels collapsed, okay, they will then open. These vessels will open and simply they will branch like normal vessels near your lungs, isn't that?
Mm-hmm.
So here lungs, like for example, and oxygenation will then take place. Now these vessels, because they are open, immediately the resistance, the pressure in the right heart will drop. The
True.
pressure here, which was increased more than the left, will suddenly drop because suddenly the vessels of the right heart has opened up, isn't that? So the
Yeah.
pressures will drop. Now the pressure will be decreased compared to your left side. So because of this increase in pressure, this will immediately push that foramen ovale towards the right side, which will make it fused with the remaining septum, and foramen ovale will be closed because of this reason. With the same concept, this ductus arteriosus, because now left heart is more powerful than the right, this shunt will behave as a left to right, isn't that?
Yes.
And so for that time, the oxygen is the factor that closes this, that shuts it down. Okay, so
Mm-hmm.
oxygen closes this ductus arteriosus.
Got it.
Okay,
Okay.
if this ductus arteriosus is not closed because of any reason, the disease is called PDA, patent ductus
Patent
arteriosus,
ductus.
or
Correct.
persistent ductus arteriosus. The correct term is actually persistent ductus arteriosus, not patent. When you,
Ah, okay.
yeah, when you see the textbooks, okay, you will realize that the textbook says persistent ductus arteriosus, not the patent, because it's a persistence, isn't that?
Mm-hmm.
Anyway, right? So now read. In fetal period, shunt is right to left, which I just discussed, right? It's normal, it's
Yes.
physiological. In neonatal period, because of the decrease in the pulmonary resistance, which I just said, because the pulmonary vessels will open, the lungs will be opened, right? So shunt will then become a left to right shunt, isn't that
True.
right? So if it is not closed now, because the newborn, the neonate, the infant is having a left to right shunt, so much blood is going into your right side of circulation, the right ventricle will undergo hypertrophy, and then eventually it will fail, right? So before
Yes.
the failure of the heart, on auscultation, you will feel a machine like murmur. Okay,
Correct.
because why a machine like murmur? Because there is a continuous flow. See, through this opening, there is a continuous flow to the right side. So this gives a machine like murmur. And this murmur is best heard on your back between your scapula, between your shoulder blades. This is the best
Ah,
location.
okay.
This is the best location where you can hear this murmur. The machinery murmur, it's a
Got
continuous murmur, and it's present both between S1 and S2 and S2 to S1. It's machinery and continuous throughout.
makes
Okay.
sense.
Now there are certain drugs that can keep the ductus arteriosus patent, like for example prostaglandins
Yes.
and hypoxia. These are the two conditions that can keep the this thing open. Now my question is, why it will remain open? I mean, I just explained you that when you take the first breath, when oxygen saturation will go up, it will close the ductus arteriosus, right?
Yes.
Suppose in the same fetus there is a shunt, there is a right to left shunt. Suppose there is what can we have tricuspid atresia, or suppose there is transposition of great vessel. Okay. Suppose there is a right to left shunt. Because of the right to left shunt, the newborn will have hypoxia, decreased saturation in the aorta, right? So
True.
that decreased concentration of oxygen is not enough to close that PDA, to close that ductus arteriosus.
Ah, okay, okay, okay. That's why it remains open.
Yeah, this is the reason. You need a high amount of oxygen to close it.
Okay, okay.
Sometimes, the only mechanism of survival in a patient with right to left shunt is the presence of the ductus arteriosus. Okay, as I explained,
Mm.
remember yesterday I explained you this thing.
Yeah, yeah, yeah. You were saying, yeah.
Remember I told you that when there is a right to left shunt, all the deoxygenated blood is going to your left circulation. Because of the presence of left to right shunt, that deoxygenated blood will again go to the right side. So it will help you in survival. So in these patients in which you have a severe right to left shunt, you will give them prostaglandins, because prostaglandins keeps the ductus arteriosus patent.
Okay, okay. Got it.
Okay, prostaglandins keeps his patent. On the other hand, NSAIDs are inhibitors of the prostaglandins. NSAIDs are given to close this ductus arteriosus in children in whom it remains open.
Okay, 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 okay. So they would have to give some sort of antibiotic. I was thinking that they would might have to do some sort of surgery for this one. But Anne
Yeah.
said if the
Before going to the surgery, you try to close it with indomethacin, NSAID.
okay,
Before
okay. So you
surgery.
would do it. You would give them indomethacin. I thought they probably wouldn't even try that.
No, no, it's written there. Look, and
Yeah,
omethacin. Just made the spelling correct for you. And
yeah.
indomethacin ends the patency of PDA.
Makes sense. And if it doesn't close because of that, then they will do the surgery. Correct?
Yeah, I mean, it will at least, let's say, for example, if previously it was 100% open, it will at least close it by 30% or 40%. It will make your
Got
surgery,
it.
isn't that? At
Makes
least
sense.
it gives you some advantage, isn't that?
Mm-hmm. Makes sense.
So remember this thing: the endomedicine, the NSAIDs can close the ductus arteriosus, whereas the prostaglandins keep it open. The concept is
Yeah.
that because in a right to left shunt, you need the this shunt to remain open, to remain patent. You give prostaglandin. So don't, by mistake, never answer endomedicine in a right to left shunt. I have seen the students marking it wrong. Okay, you need to give prostaglandins to keep it open in the patient with right to left shunt. Okay, whereas if there is no right to left shunt present and the patient is simply presenting to you with a machinery murmur with nothing else, no cyanosis, you can give indomethacin to close this. Okay.
Hold on a second. Wait a second. Wait a second. Let me just get this clear. So you're saying that all of these right to left shunt that we have, transmission of the great vessels, tricuspid atresia, all these, since they are right to left shunt, the
Mhm.
treatment for those ones is that you have to give them prostaglandins. Is that what you're trying to tell me?
Yeah, I'm saying in any right to left shunt, because they are having cyanosis, they are having decreased oxygen saturation, you need to keep the ductus arteriosus open, so you give them prostaglandins to keep the PDA open so that the shunting can be left to right. From the right to left shunt, the deoxygenated blood is coming to your left heart, and then because of the PDA, it's going back into the right heart. So it's actually treating it. It's actually
No,
happening.
I'm confused. I'm a little bit confused because I'm not sure if you're talking about this particular treatment just for patent ductus arteriosus, or you're talking about all the right to left shunt. You
I'm
should
talking
keep it open.
all first talking about all the right to left shunts. Okay,
Okay, all of them.
all the right to left, you need some left to right shunt for survival. For example, let's suppose there is a tricuspid atresia. In tricuspid
Hmm.
atresia, blood can go into the right ventricle, so the patient would die.
True.
Right? So you need some sort of left to right shunt for the survival. If there is no left to right shunt, the patient will die simply.
See, I'm glad you pointed that out because I myself would tell them indomethacin, close that. But now you explained it, it makes sense. You have to keep it open, otherwise they will die. That makes sense.
Exactly. They will die. I mean, they will have no other way for oxygenation. They will
Yeah.
simply die. So keep it open,
It
right?
yes.
Whereas in a simple, left to right shunt presentation with no cyanosis, you can simply give them endomethacin to close it, and then you will go for the surgery later on. Okay.
Got it. Makes
Now,
sense.
from the exam point of view, this is not enough. I mean, now you at least you know three things. One is the prostaglandin, which keeps it open. Another is the oxygen, which closes it, right? Endomethacin also closes it, right?
Yes.
So now you know at least. Let's come here. Let's make a small list. So it means you are saying that the prostaglandin, the PGs, and hypoxia decrease oxygen. This will
Hmm.
keep it patent, right? I'm just writing patent.
Yes.
Increase the
Like
patency.
remain it, they will remain the patency, keep it open, correct.
Whereas it will be closed, the ductus arteriosus will be closed with increased oxygen saturation, right?
Mm-hmm.
And NSAIDs, because NSAIDs are
Yes.
inhibitors of prostaglandin, right?
Yeah.
From in the exam, there are certain other things that can close your PDA. The exam is not that easy, that's why I'm discussing it. These are bradykinin. Bradykinin can also close the PDA. Okay.
Well, of course, bradykinin can do that because they're inhibitors. Well, what about cyclooxygenase? Well, no, I don't think they increase prostaglandin.
Yeah. As acetylcholine can do that. Okay.
Okay.
Histamines can also do that. Histamine also closes the PDA. Okay.
Mm,
Catecholamines can also close the PDA.
okay.
So these are all the substances that can close your PDA. Okay. NSAID,
Mm,
increasing oxygenation, bradykinin, acetylcholine, histamine, and catecholamines. They will keep your this thing, the ductus arteriosus. They will close it, right?
mm-hmm.
Now, so this was the thing that you should be knowing about the PDA, the type of murmur that you can get, when you will close it, when you will open it, right? Anything else? Any question?
No, it's
Huh?
it's it's good.
Okay. Now,
I
one
feel
more,
it's good.
yeah, one more thing from exam point of view. That is, the persistent ductus arteriosus is associated with congenital rubella. Mothers who get rubella infection, that rubella can transmit to the fetus and can cause persistent ductus arteriosus. Okay.
So
So not
basically, so it acts on that ductus arteriosus, like it prevent it from closing it. Basically, if it would even want to, it would not
yes,
because
yes.
it
I mean, even in
okay.
step 2 and step 3, you will see a strong association of rubella with persistent ductal arteriosus.
Makes sense. Makes sense.
Very strong association. Okay, so rubella is associated with PDA. Okay, remember.
Okay.
Anyways, now the next one, the Eisenmenger syndrome. We discussed it about yesterday as well. Let's quickly finish it. Eisenmenger syndrome is a simple condition, okay, in which the patient who was previously having a left to right shunt now presents with cyanosis because the shunt has reversed. Okay, because of so much chronicity of that shunt, too much blood was going to the right heart. A time will come when right heart pressures will go up compared to the left,
Yeah.
and there will be a time when the shunt will reverse. When the shunt reverses, this is called Eisenmenger syndrome. See that
Yeah.
uncorrect left to right shunt increase the pulmonary flow, pathological remodeling of the vasculature, pulmonary hypertension, right ventricular hypertrophy will occur, shunt becomes right to left. Okay, and there will be cyanosis, there will be clubbing, there will be polycythemia. Remember, anytime you have cyanosis or hypoxia, the patient will get polycythemia. Any reason? Anyone who is having cyanosis or hypoxia,
Now there, I mean, because
the
shutting
reason
the
is
blood.
that, let me tell you, let me tell you, the reason is that in cases of hypoxia or cyanosis because of any reason, kidney releases a compound known as
Hello.
erythropoietin. That erythropoietin can cause polycythemia.
Sorry, can you repeat? I think you just got cut off. I couldn't hear anything. What did you say
Oh,
about the polycythemia?
I was saying, look, whatever the cause of hypoxia or cyanosis is, in any case of hypoxia or cyanosis, kidney releases a compound known as erythropoietin. That erythropoietin goes to the bone marrow and increase the formation of red blood cells, which causes polycythemia.
Ah, okay. Okay, got it.
It's mechanism. It's just a mechanism to compensate. You know what? Because in cyanosis or hypoxia, you have decreased oxygen, right? So what body try to do? Body try to increase the number of transporters, which are red blood cells, to treat that hypoxia or cyanosis on their own. Because obviously the body cannot do the surgery on its own. It cannot treat the heart defect on its own. So what it do? It simply gives the output of the red blood cell. It gives a large number of the output. Are you getting me?
Mm-hmm.
So it's just a matter of compensation. Remember, any cause of cyanosis or any cause of hypoxia, the kidney will release erythropoietin. Erythropoietin will go to the bone marrow and increase the output of the red blood cell, which will cause polycythemia. Are you getting me?
Yes, makes sense.
Remember that when you will solve the question of congenital heart disease, you will come across the hemoglobin to be very high, 19, 18 all the time. Okay, don't get confused. This is because of erythropoietin. Okay, and this is sometimes
Okay.
sign of underlying cardiac abnormality as well.
Okay, makes sense.
Plus this clubbing. Why there is clubbing? Any idea?
I'm thinking maybe oxygen, decrease oxygen, maybe. I
Yes, you're
don't
right.
know.
First of all, tell me what is clubbing. What do you mean by clubbing?
Like the nails, like you look at your nails and they go
Yeah.
like downward, the
Yes.
shape of
The
it.
nails will be very thick, okay, and they will
Yeah.
acquire a moon shape. So this is called clubbing. Clubbing is seen in any cases of hypoxia, which is related to cardio or pulmonary system.
Mm-hmm.
I mean, clubbing can be can be a manifestation of some congenital heart defect, or it can be a manifestation of congenital lung disease, like recurrent. Someone who is having recurrent infection, someone who has a COPD, someone who has emphysema, someone who has bronchiectasis, someone who has cystic fibrosis. So remember, hypoxia secondary to cardiopulmonary cause can cause clubbing. Are you getting me?
Yes, yes, yes. I'm listening.
Now the exam question. The exam says, okay, and we understand that you know about hypoxia. This low
Yeah.
oxygen goes to your nail bed. Okay. Now,
Mm-hmm.
how do the nail know that they need to be increased in size now? The answer is the platelets near the nail beds release a compound known as platelet derived growth factor, PDGF, in response to hypoxia, which causes clubbing. Remember, there is a reason for everything in USMLE.
Okay.
Okay, so in hypoxic condition because of cardiopulmonary disease, okay, the clubbing is because of the platelet-derived growth factor which causes clubbing. Are you getting me?
Yes. Makes sense.
PDEF. Polycythemia is because of erythropoietin. Okay, so now remember, in right to left shunt, there will be early cyanosis, there will be clubbing and polycythemia. In left to right shunt, there will be late cyanosis, clubbing and polycythemia.
Okay. Okay. Okay.
Okay, so this was Eisenmenger syndrome. Any question?
Okay, so the platelet drive, so platelets are the one that will detect that there's low oxygen and it's gonna release that platelet drive growth factor, which in turn is gonna make those nails like thicken up.
Yeah. Later will
Okay.
release the PDCF, okay, which will cause clubbing. Okay.
Okay, got it.
Right. Now there's a table, which is from high yield for exam point of view because I have seen that too many exam questions, they play with oxygen saturation in the right atria, right ventricle, and they try to confuse you. So let's
Okay.
take the table. Okay, I'm just putting everything on one page now, so that you
Okay.
never make mistake now. So you have three left to right shunt, which are your favorite ASD,
Yes.
okay, then your favorite VSD, then everyone's favorite PDA, right? You have got
Yeah.
these three left to right shunt,
Yeah.
isn't that? Now,
Yes.
so from exam point of view, they give you, these things to confuse you. Let me first, write them down and then explain.
Okay.
Yeah, we have got systemic arterial oxygen, okay, systemic
Mm-hmm.
systemic partial pressure of oxygen, okay, it represents the systemic arterial oxygen, okay.
Okay.
And you have got right atrial partial pressure of oxygen, isn't that?
Yes.
Then you have got right ventricular partial pressure of oxygen, okay.
Mm-hmm.
You got what? Then you have got pulmonary artery, isn't that?
Yes.
Partial pressure of oxygen, okay. And lastly, you have got the pulmonary artery pressure itself, or you can say pulmonary artery flow.
Okay.
Anyways, now tell me what will happen to the systemic partial pressure of oxygen in ASD, VSD, and PDA.
Um, so the systemic oxygenation, I mean, it should go down.
Initially, it will remain the same. Okay,
Okay.
yeah, because some of the blood is going to your right side because of the left to right chain, and some is still going into the body, right? It's still oxygenated. So systemic oxygen will be the same. It will not be
Okay.
decreased, right?
Okay.
Now, in ASD, don't you think the right atrial PO2 will increase because of the left to right shunting?
Yeah, it would increase because you're
What
shunting
about
now
the
back.
right, yeah, what about the right ventricular? In ASD,
Yeah. Well, yeah, I mean, it should increase as well.
very good. What about the pulmonary artery?
Yes, should
Very good.
increase.
And because increased blood is coming, so the flow will also increase. Very good. Now, what about the
Yes,
VSD? Right atrial partial pressure oxygen and the VSD?
it will increase.
No, it will not change. It will be the same as in the right atrium, normal deoxygenated blood which was coming. Look, VSD is present at the level of ventricles. Remember,
Yes,
not
yes, yes. So it would not. Yeah, makes sense.
right. So it will be. Look, the dash mean it will be the same that should be there in the right atrium. Okay,
Yes.
deoxygenated blood. It will start to have increased partial pressure of oxygen from the ventricles. In VSD, you have increased oxygen from the ventricles. Remember this thing. Okay. Then obviously from after ventricle, it will go into the pulmonary artery and flow will also increase. Isn't that?
Yes.
Whereas in pulmonary, in the PDA, because PDA is now more far away. It's not in the zone of the right atria, so it will have a deoxygenated blood. It's not in the zone of the right ventricle, so it will also have a deoxygenated blood. It starts on the
Yes.
pulmonary. So the pulmonary artery partial pressure oxygen will go up.
Okay. Makes sense.
Okay. So this table tells you about when they put a catheter in your right heart and they measure the partial pressure of oxygen, if they tell you, this is a very difficult question actually. Right now it looks very simple to you because we just made a table and I just tell you about everything. Okay, but when you see the exam question, they give an exam question like this. when they put a catheter inside your right heart, they compare the oxygen saturation and it's very high. So if you are getting the oxygen saturation high starting from the right atrium, it means that the patient is having a ASD. Okay, down below. If you are having an increased oxygen saturation starting from the right ventricle, it means it's a VSD. And if you are getting an increased oxygen saturation starting from the pulmonary artery, it means it's a PDA.
Got it. Got it.
Okay. So now when you see the exam question, it will now become a little easy for you because now we have discussed all the three diseases and their oxygen saturations at as a table. Now it will be easy for you. You will not get confused with that. Okay.
Mm-hmm.
So very good. Now let's move forward.
Yeah.
Now the next topic in front of you is the coarctation of the aorta. I know that you may have heard about a coarctation as well, isn't that? Now,
Yes.
coarctation simply means the narrowing of the aorta means the narrowing of the aorta, right?
Yes.
Now, the beautiful thing is that coarctation usually happens near the insertion of ductus arteriosus. Okay, it is
Mm-hmm.
near the insertion. They didn't tell you that it is before the ductus or it is after after the ductus, isn't that?
Yeah. Yeah.
So, our same diagram that we are drawing again and again. I mean the same heart. Okay, with the four chamber in it, right?
Mm.
And then as usual, we'll make the our favorite arteries, the pulmonary artery and the aorta, right?
Yes.
Remember, here we make your our favorite PDA. Now, question. They said in the book that this thing, the coarctation is near the PDA, but where? Is it here? I mean, proximal to the PDA, or is it below? A valid question, isn't that?
Yes.
So this is the reason the coarctation is divided into two. The periductal, okay, periductal means narrowing of the aorta above the site of insertion of your PDA, and postductal
Oh.
means the narrowing of the aorta below the PDA.
Oh, okay. Okay. Okay.
Okay, so this is periductal coarctation or postductal coarctation. Are you getting me?
Yes. Yes. Yes.
Okay, remember they are taking this as a reference. Remember, in someone who hasn't got a PDA patent, because usually in normal neonates the PDA closes, it obliterates, right? It becomes
Yes.
ligamentum arteriosum. Do you know that the remnant, the
Yes.
yeah, the mature thing of the PDA is called ligamentum arteriosum. It becomes a LA. So you can say
Yes.
that proximal to the ligamentum arteriosum is the preductal coarctation, and below and distal to the ligamentum arteriosum is your postductal
Post.
coarctation. Okay. Now the associations are absolutely different for preductal and postductal. I mean, before we discuss the coarctation on its own, let's first discuss the association of preductal and postductal. Okay.
Okay.
Preductal coarctation is seen in someone with a Turner syndrome.
Okay.
Okay, so the preductal type is associated with Turner syndrome. Remember this thing.
Okay.
Okay, the Turner syndrome is X naught. Okay,
Yes. Yeah.
whereas the postductal coarctation is seen in a disease known as bicuspid aortic valve.
Okay.
Okay, so these are the associations. Remember that exam wants you to know the associations very well. Okay,
Okay.
this is the thing. So this is the concept. Okay, preductal with Turner syndrome, postductal with bicuspid aortic valve. Any question?
Nope.
Right? Let's first it again. Okay, so
Okay.
aortic narrowing near the insertion of the ductus arteriosus, we just discussed the two types associated with bicuspid aortic valve and Turner. Look, it didn't tell you which one it is with. Okay, now you know the bicuspid one is with the postductal and the Turner
Yeah.
with the preductal, right?
So,
Now,
so when they say quotation of the aorta, since we don't know if it's where is exactly, so we just remember it that they're just talking about they could be both pre or post.
no, 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 no. Look, when the exam wants to test you on the association, then it will tell you that it's pre or post. Okay,
Okay.
when they want you to test with the association, look, association is bicuspid aortic valve. Bicuspid aortic valve itself can cause aortic regurgitation in the beginning, and later on it will cause aortic stenosis. Remember something like that we discussed?
Yes. Yes. Yes.
Right? So when the question starts with the fact that a patient was having aortic regurgitation, and when you do the echocardiography, you saw narrowing of the aorta. So it means we are talking about post ductal coordination. I mean, they can phrase the question like this. You just need to put the same knowledge on the questions then. That's why we're
Okay.
discussing
Okay.
these associations. Whereas, whatever type of coarctation is, the presentation in both of them is the same. That is hypertension in the upper extremities and hypotension in the lower extremities. Can you tell me why?
Yeah, because the difference in the flow of the blood, right? So there's a
Correct.
higher pressure upward because of the
Yeah, because
narrowing.
there is no
There's not
narrowing
enough.
in
Yeah.
the vessels above, right? Because there is no narrowing in the vessels above on the upper extremities. That's why the blood flow will be good and there will be increased blood pressure in the upper extremities. Whereas because there is narrowing, there the decreased amount of blood will be going to the lower extremity. So that's why there will be hypotension. That is a brachiofemoral delay. Okay,
Yes.
the blood pressure in the brachial artery will be more than the femoral artery. This is the thing that this means with the brachiofemoral delay. Now the question, one more thing. What is the relation of this ductus arteriosus with the subclavian artery? This is also a very important exam question. Remember, remember that
Subclavian artery.
coarctation of aorta is always distal to subclavian artery. Remember that subclavian artery branches becomes the axillary artery, and axillary artery supplies your upper limb bilaterally like this. Okay, subclavian artery becomes your axillary artery, and axillary artery becomes your brachial artery, right?
But isn't it also the subclavian artery is a branch of the aorta?
Yes,
Yeah.
that is what I'm saying. Coarctation is always distal. I mean, first the aorta will give rise to a subclavian artery. After that, you will find the coarctation. Never before that.
Ah, okay, okay, okay. I see what you're
This is
saying.
the reason. This is the reason you are having increased flow to the subclavian artery and it's going to your upper limb. That's why you're having hypertension in the upper limb. There is a reasoning.
Okay.
Okay, there is a reasoning behind it. Okay, now one more thing. Because there is a one branch of subclavian artery which is called internal mammillary artery. Okay, that
Okay.
branch that branch supplies your thorax, your chest wall. Okay, so as well as your ribs. So what happens is that when you're having a coarctation, because distal to a coarctation there are branches that are going to your ribs as well, they are going to your chest as well. Okay, now because you are getting decreased flow to those areas, so what happens, the branch of the subclavian artery, the internal mammillary artery, will give rise to collaterals that will now
You're
supply your huh?
you're saying sorry, I'm just trying to clear what you're saying. You're saying intramaxillary or intramedullary arteries?
Mammillary.
Maxillary, right?
No, mammillary.
Oh, mammillary, intramammillary will give rise to intercostal arteries, correct?
No, it will give rise to collateral branches that will give blood to the intercostals as well. Okay. Otherwise,
Okay.
because intercostal arteries are branches of the aorta itself. Let me tell you how. Let me draw it in front of you. Suppose this
Okay.
is your aorta. Okay. Okay. This aorta simply gives small branches known as intercostal arteries like this, and they supplies your rib cage like this.
Uh-huh.
These are your intercostal arteries. Okay.
Yeah.
And so on, because your 12 rib you can make like this. Now just imagine, because you have a narrowing on proximal end, before the appearance of the intercostal artery, you have a coarctation of aorta, right? When
Uh-huh.
decreased air will go here, it is natural that in all of these intercostal arteries the blood flow will be decreased, isn't that
Yes.
common sense?
Yes, yes, yes.
So what happened there? The blood vessels proximal to that coarctation, whatever blood vessels are there, will give collaterals here, okay, and they will now put blood in these intercostal vessels.
Oh, the collateral. Okay,
Yeah,
okay.
the collaterals will supply the intercostals, okay, like this. Look, when a intercostal artery is enlarged, they will now enlarge because the blood flow is coming from the collateral circulation, okay, and you will see
Yes.
notched appearance on the X-ray, rib notching
Okay.
also,
Got
okay.
it. Got it.
This is the thing. Eventually, because of severe coarctation, the heart can fail. Now, my question. Remember, because your kidneys are also getting decreased blood supply now, isn't that?
Mm-hmm.
As a mechanism of autoregulation, kidneys will do tubuloglomerular autoregulation. So they will secrete renin because of the hypotension. Renin will activate the renin angiotensin aldosterone system, and it will keep on absorbing sodium and water. Okay, because this because the kidney didn't knew that, the proximal to it, there's a coarctation which is doing that. The kidney just is, having hypertension, so it's releasing renin, it's releasing angiotensin 2. So angiotensin 2 will increase the blood pressure, and sodium and water absorption will be more and more. So what happens that because of too much fluid, ultimately the heart will fail.
Yes.
Okay, and the blood pressure will go so up because of angiotensin 2 as well, because of the narrowing as well. So there will be baryonerism. There can be
Because there's already too much hypertension. So now the kidneys, because they're thinking, okay, we're not getting enough blood supply, they're gonna create their own.
Right, so this is a very bad
Yeah,
cycle.
increase them.
Can be dysphysia,
Yeah.
like these things that you can see here. There can be cerebral hemorrhage because of rupture of the aneurysm, aortic rupture, heart failure,
Yeah.
everything. Right, so this was all about the coarctation of aorta. And remember that on the abdomen, on the chest, when you palpate the intercostal arteries, they will be palpable. Sometimes the intercostal arteries in coarctation of the aorta become palpable.
Makes sense.
Okay?
Makes
Yeah,
sense.
because they become pulsatile. Any question?
No.
Okay, now one more exam related question.
Hold on. Yes. Question. Sorry. Okay. So increased risk of cerebral hemorrhage. So since you already have increased amount of hypertension in your upper portion, right? So
Yeah.
is that the sign, and that's what's causing, because now there's increased amount of pressure in your brain too, that could lead to hemorrhage,
Yeah,
and that could cause all these. Okay.
yeah. Like
Got it.
like hypertension is the cause of hemorrhagic stroke in any other patient. Same
Yes.
reasoning. Okay.
Got it.
Okay.
Got it.
Now, as I told you that the coarctation always arises distal to the subclavian artery, right?
Yes.
Yes. Now the question is, you have two subclavian artery. One arises from the right side of the aortic arch, and one arises from the left side of the aortic arch.
Mm-hmm.
With which subclavian artery is distal to? This is a valid question. It's like this. Let me draw it first. I mean, you have arch of aorta placed like this. This is the arch of aorta, isn't that?
Yes.
Here is your one subclavian artery, and here is your another subclavian artery. Right now, I'm just drawing the subclavian artery.
Okay.
Question: distal to which of these subclavian artery is your coarctation? I mean, this is right subclavian artery. This is left. Distal to which subclavian artery is your coarctation? Valid question, isn't that? Exam generates question like this.
Yeah. It is. It is valid question. Yeah.
Just think. For this, you need to remember the anatomy. Anyways, look.
I mean, maybe. Okay. Yeah, go ahead.
Look, right subclavian artery supplies your upper limb blood flow, okay? Left
Mm-hmm.
subclavian artery supplies the blood flow to upper limb of the left side, okay?
Yeah.
This supplies the upper limb of the right, and this supplies the upper limb of the left, okay? It means that because we just said hypertension is in the upper body is being perfused. So coarctation is distal to the left subclavian artery. So there is your left ventricle. The heart is placed like this, okay? The aorta is coming out from the left ventricle like this. This is LV, okay?
Mm-hmm.
So this is like this. So when the blood flow comes out from this thing, okay, and there is a coarctation here, blood will go here and blood will go here, and the other vessels as well of the head and neck. This is the concept, okay? So distal to the left
I
subclavian artery is your
got.
coarctation. Any
Makes
question?
sense. Makes sense. No. Okay. Not this. I don't have a question. I have another question.
Mm-hmm.
Uh, there it says endocarditis. I'm not understanding, how does hypertension causes endocarditis
No,
in
no,
the
no.
heart?
It's not with the hypertension itself. It's saying possible endocarditis. Look,
Okay, possible.
it
Because I'm like, it's not making
is
any.
a it is a rule in pathology that whenever you have obstruction, you have obstruction in a hollow tube, proximal to that obstruction, you can get infection. It's a pathology rule. Anywhere, you can apply
Okay.
this rule anywhere. Let me explain you how.
Yes.
For example, you have a gallbladder. Remember, you have a gallbladder here in your
Yes. Yes. Yes.
right. From the gallbladder arises the cystic duct, right?
Yes.
Suppose you have a stone in the cystic duct, polylithiasis. If you don't remove
Okay.
that stone, look, this whole gall bladder behind, distal to this, you know, stone is become a hollow tube, right? So whenever you have
Yes.
a obstruction of a hollow tube, this place can now get an infection. So patient can get cholecystitis. Same reason, cholelithiasis, that's how can lead to cholecystitis. Similarly, you can apply the same concept on your let's say salivary gland. Okay, if you have, like, this is the parotid gland, a big gland, parotid gland, which opens via the Barthen duct distal to your third molar tooth with an opening, right?
Yeah.
If there is an opening, if there is a blockage in your salivary gland because of a stone or because of tumor, the salivary gland can develop cyalolithiasis. The salivary lithiasis is basically the stone itself, and cyaloadenitis is the inflammation of the gland.
Mm-hmm.
Okay, cyaloadenitis is inflammation, and cyalolithiasis is a stone. Okay, so any obstruction in any part of the hollow tube can lead to infection, right? Similarly, if you have infection here, also if you have an obstruction here, so proximal area is like a hollow tube here, right? So
Yes.
that tube can get infection anywhere. Same rule of pathology. Pathology is very easy. You just need to know some rules. That's it. Okay.
Got it. Got it. Yeah.
Yeah. But this endocarditis is very rare. Okay? That's why it's even here possible endocarditis, because the coarctation usually present in children, and these children usually die before even getting endocarditis. It's a very rare late complication. Usually these children die
Got
before
it.
even getting. Okay, let's move forward now.
Yeah.
Yeah, very good. Okay, the next thing that you can see in front of you is the congenital cardiac defect and their associations. Okay, just let's quickly go through it. The alcohol can lead
Yeah.
to PDA, ASD. Pathology of all of you already know that the rubella is a PDA. It's very important. Okay, just remember the PDA. Forget about the other two. Okay,
Okay.
even remember the PDA, it will help you in all the steps. Down syndrome, just remember the endocardial cushion defects. Endocardial cushion, remember, it leads to the formation of the ASD as well as the VSD. Remember, it forms the septa of not only the atrial septa and as well as the membranous septa of the VSD. Okay, so if there is a
Yes.
Down syndrome which has neural crest defect, the pathology is actually neural crest defect. Neural crest did not go to your endocardial cushion, which leads to the formation of ASD and VSD. And the type of VSD that is associated with the Down syndrome or the neural crest defect or the endocardial cushion defect is membranous type of VSD, not the muscular type.
Yes. Yes.
VSD have
True.
two types, membranous and muscular. With the Down syndrome, with chromosomal abnormality or with endocardial cushion defect or with neural crest defect, it is the membranous type of VSD that develops. Okay. And with the
Yes.
infant or diabetic mother, there is transposition of great vessel. We already discussed that. With Marfan syndrome, because Marfan syndrome is a connective tissue disorder, so that's why there will be mitral valve prolapse. Okay, there can
Yeah.
be aortic aneurysm, aortic dissection, aortic regurgitation, mitral regurgitation. Okay. Lithium,
Yes.
we discussed yesterday, the Epstein anomaly, right? Turner syndrome, okay, is associated with bicuspid aortic valve, coarctation of the aorta. Williamson is supravalvular aortic stenosis. It's very low yield, okay? It's never tested in the exam. The 22q11 syndrome, Turner have usually radiology for us, very low yield. Okay, so just
Okay.
remember the yield thing from this table and move on. No need to, no need of spending more time on it. By
Okay.
the way, 22q11 is also known as Dijor syndrome.
Yes. Yes. Yes.
Okay, 22q11 is the Dijorge syndrome. This is one thing that is important in exam. Anyways, then comes your hypertension. Now, some easy topics. Hypertension, if you simply know it, the blood pressure of more than 130 by 80, right?
Mm-hmm.
Now, risk factors for the hypertension, simply, just go through it for, once. Increasing age, obesity, diabetes, physical inactivity, excessive salt intake, excessive alcohol, cigarette, family history, African Americans, right? More than a Caucasian and
Yes.
Asian. So these are some risk factors that are associated with these things, hypertension. So it means that blacks has the highest risk of hypertension.
Mm-hmm.
Okay, black, then white, and then Asians. So black, white,
Yes.
and brown, like this. Anyways, so hypertension, 90% of hypertension in the cause is idiopathic. It's called essential hypertension. There is no reason behind it. Okay,
Okay.
90% of the cases of hypertension are actually essential hypertension. There is no cause. You need to understand this. Okay, there is no
Mm-hmm.
cause getting a hypertension in 90% of the world population. It's just the risk factor. That's it. You need to control the risk factors to modify the hypertension. You need to treat them with a drug. The rest of the
Okay.
10 cases has some causes, and these are called secondary hypertension. Okay,
Okay.
secondary. Now remember, for this you need to understand, the causes that can increase the blood pressure. For example, the first thing that comes in your mind is the kidney. Kidney can increase the reabsorption of salt and water. Kidney can secrete renin and angiotensin and can cause hypertension, right? So the
Yes.
first thing that comes in your mind is something that decrease the blood flow to the kidney. Because we just discussed in the quotation that when there is a low blood flow to the kidney, kidney will release the erythropoietin. Oh, sorry, the renin. Remember?
Yes, yes.
There are some pathological disease in which the kidney has got low blood flow. These are like this. For example, let's draw your kidney now. This is your kidney,
Okay.
let's say. Okay, and
Yeah.
here a renal artery in it. Okay, the kidney supplies a renal artery, right?
Yes.
The disease known as renal artery stenosis. Renal artery stenosis is a disease in which the renal artery is stenosed.
Okay.
When when the renal artery is stenosed, decreased blood will go into it, isn't that?
Yes.
So kidney will have hypoperfusion. Now kidney doesn't know that hypoperfusion is because of renal artery stenosis or because of low blood flow or because of or because of hypotension or hemorrhage or dehydration. Kidney is just receiving low blood flow. That's it. And because of the tubulocular feedback, it will release a renin, angiotensin, aldosterone system, the RAS. This RAS system
Yes.
will increase the vasoconstriction of your blood vessel. It will increase the sodium and water reabsorption as well, isn't that?
Yes.
So remember that renin and renal artery stenosis is seen in elderly. This is a disease of elderly basically, not young.
Okay.
Okay. Similar to renal artery stenosis, there is another disease which is present actually in young patients. Okay. So let's make one more kidney. Okay. In
Okay.
the disease of the young patient, the name is fibromuscular dysplasia.
Okay.
Do you know what is fibromuscular dysplasia? In fibromuscular dysplasia, there are bleedings in this renal artery. So there are areas where there are constriction and dilatations, like this. So because, and even on the ultrasound of the renal artery, okay, you will see this bleeding.
Sorry. So you only see fibromuscular dysplasia. Are you just doing an example like you'll see it in a renal artery, or you're saying that it could occur anywhere?
Most likely, most commonly, it occurs in the renal artery.
Okay.
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 Most commonly, it occurs in renal artery, and from USMLE, even for step one point of view, it's a cause of secondary hypertension.
Okay.
Okay, and remember, it is present in young female, not in elderly. This renal artery stenosis, this thing is in elderly, whereas the second,
Elderly males, or it could be males or females. Elderly
uh,
males or females.
any one of them. Okay,
Okay.
whereas the fibromuscular dysplasia, this thing is present more in young female. You need to remember this thing, and rest of the thing
Okay.
is exactly the same. Kidney is being hyperperfused, it will release the renin, angiotensin, aldosterone system, and blah 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 blah, and then you will see the same
Anyways.
thing, right?
Okay.
Third cause of the secondary hypertension can be, remember on top of your kidney is your adrenal gland sitting like this, isn't it?
Yes.
Adrenal gland can produce aldosterone. If it produces too much aldosterone, I mean if it's the aldosterone secreting tumor, this tumor will really increase the absorption of too much of sodium and water and can cause hypertension.
Yes. Yes.
I mean these are some,
I believe it's by glucocorticoids, right? I think it's
look,
glucocorticoids.
there's an aldosterone secreting tumor itself and there's a steroid producing tumor as well. Okay, whatever the thing is, it has to have the action of the mineralocorticoid, which increase the
Sorry,
sodium and
what
water.
is sorry steroids? Okay, steroid action, aldosterone. They're both okay. Mineralocorticoids. Okay.
Yeah, ultimately they should have a mineralocorticoid action to reabsorb sodium and water. The main thing is the absorption of sodium and water to cause the secondary
Makes
hypertension.
sense.
Okay,
Makes sense. Makes sense. Yeah.
right. So remember, 90% of the cases of hypertension are idiopathic, which is called essential hypertension, and secondary causes of hypertension can be renal artery stenosis, can be fibromuscular dysplasia. I just tell whenever you can see them. Okay, and the primary hyperaldosteronism, which I just told you. Okay,
Yeah.
so
Yeah. True.
whatever the cause of hypertension is, you need to understand the difference between hypertensive urgency and emergency. Too much hypertension can lead to hypertensive urgency or emergency. See the difference.
Oh,
Hypertensive urgency is severe blood pressure more than 180 by 120 without acute end organ damage. Now, what the hell is acute end organ damage? And how in the exam you will come to know that whether there is end organ damage or not.
yeah.
Now, the thing is that when severe hypertension, I mean more than 180 by 120 is causing, let's say, angina in the patient, heart attack. Okay, so when they tell you the BP is more than 180 by 120, and there is the patient is having increasing troponins and CKMB or ECG changes, it means an end organ damage, right?
Yes.
So when there is end organ damage, it is not hypertensive urgency. Remember, in order to
Mm.
diagnose hypertensive urgency, the blood pressure should be more than 180 by 120 without any or end organ damage.
Meaning the EKG should be normal.
Everything, look, ECG should be normal, your troponin should be normal, the patient should be fully conscious. Okay, the eye fundoscopy exam should be fully normal, the echocardiogram should be fully normal, the kidney creatinine should be fully normal, everything should be normal. So it should be without end organ damage, then it is called hypertensive urgency.
Makes sense.
Whereas hypertension emergency means you have severe hypertension, the same 180 by 120, with evidence of acute end organ damage. And in the exam, end organ damage will be presented to you by ECG changes, or by increasing troponins or CKMB, or by encephalopathy. Encephalopathy means altered level of consciousness of the patient, right? Or stroke, or
Yes.
retinal hemorrhage, or exudate papilledema on that fundoscopic examination, right? Anemia, preeclampsia, eclampsia, these are called hypertensive emergencies. Okay.
With what about the blood pressure? The blood pressure should be extremely high.
Yeah, more than 180 by 120, as I said.
Okay, got it.
Okay, it should be more than 180 by 120. So, any question? Remember, hypertensive emergency is also known as malignant hypertension.
Okay, got it.
Okay. Hypertensive emergency is also called as malignant hypertension. I mean, these are some terms that confuse in the exam. So, emergency is also called malignant hypertension. And what is persistent diastolic hypertension?
Persistent?
Yeah, persistent diastolic hypertension.
Well, that's when you have a continuous amount of blood backing up into your ventricles. Um,
No. I mean, the definition simply is when a diastolic pressure is more than 130. This is called hypertensive crisis or persistent diastolic hypertension.
okay,
Okay. I mean, you should know these definitions. They will just simply ask you the diagnosis or what's going on.
got
Okay.
it, got it.
So what is this thing? Hypertensive crisis or persistent
No,
diastolic?
but hold on a second. But persistent systolic is greater than 130, but now you're saying
No,
persistent diastolic.
I said persistent diastolic. I didn't say persistent systolic. I said persistent diastolic.
Yeah, I know, but then here, right there, if you take a look at the top, it says persistent systolic is greater than 130. So how would you differentiate between the two?
Oh, no, 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 no. Because we are talking about hypertensive crisis. Systolic, look,
Oh,
yeah, systolic and diastolic. You have two types of blood pressure, right? Systolic blood pressure and diastolic blood pressure. This thing, if this diastolic pressure goes up like more than 130, this is very severe condition. It can kill the patient. It's hypertensive crisis.
oh, it's crisis. But whereas, oh, if it's greater than 130, then this is just the normal hypertension. Okay.
Okay, look, we're not talking about systolic. Understand the difference. Look, in hypertensive urgency, it was more than 180 by 120. In emergency, it was also 180 by 120 with other organ damage. When the diastolic BP goes more than 130, I'm not talking about systolic. Systolic can be 180. When it's more than 180 and the diastolic is more than 130, then it will be called as crisis.
Got it. Got it.
Okay? Crisis is a very dangerous condition. What is hypertensive encephalopathy?
I mean, I mean, in the brain. So you have like too much increased pressure inside the brain, build up
No.
hemorrhage or whatever.
When severe hypertension will lead to altered level of consciousness in the patient. Okay, it is called hypertensive encephalopathy.
So there will be more conscious or there will be less?
No, no, altered level of, I mean, patient will be dizzy. Patient will not be knowing anything. He will not be able to know where am I. Fully
Okay,
delirious.
okay.
Patient will be delirious.
Got
Okay.
it.
Yeah, I mean he will be somnolent. Sometimes the patient can even go to the coma in hypertensive encephalopathy. So remember,
Okay.
having encephalopathy is a broad term. Encephalopathy simply means having altered level of consciousness, having somnolence, having coma. The causes of encephalopathy are, it can be because of cirrhosis. When cirrhosis causes the encephalopathy, okay, It simply presents because of the liver marker. You will see the increasing liver marker. You will see increased ammonia, because we have already discussed the GI. You should have idea up till now, right?
Yes.
Right. So it could be because of the liver, the encephalopathy. Similarly, the encephalopathy can also be because of renal disease, uremia. It is then the renal disease associated with encephalopathy is called uremic encephalopathy.
So hypertension in encephalopathy, that it's basically like a hypertension emergency, basically.
Yes, it's a subtype of hypertensive and emergency. Very good. Okay.
Yeah.
So I'm just
Yeah.
telling you the different types of encephalopathy. You have got hypertensive encephalopathy, you have got uremic encephalopathy, you have got cirrhotic encephalopathy, okay, and you have got electrolyte induced encephalopathy as well. So there are different causes of encephalopathy. Always look out for the cause whenever you get a case of it. All right.
Yeah.
Anyways, now look at the predisposed to. Now, whatever the cause of hypertension is actually an increased afterload for your heart. Okay, when the afterload for the heart goes up, okay, initially the heart will try to compensate by increasing its pressures. It will generate hypertrophy. There will be concentric hypertrophy in the heart.
Oh, okay, okay, okay.
Okay, so when there is hypertension, it behaves like an increased afterload. The heart will generate more pressure, but leads to concentric hypertrophy. And this hypertrophy of the heart will decrease the chamber size. It means the patient will have diastolic heart failure.
Yes,
Can
yes,
you
makes
recall
sense.
something like that?
Yes, 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 yes.
Okay. This heart failure is a type of diastolic heart failure, not systolic. I don't know why they didn't write this fully. In the exam, they always ask it differently. The cause of systolic heart failure or cause of diastolic heart failure. So hypertension is the cause of diastolic heart failure. Remember now,
God.
because hypertension is a pressure state. Hypertension is a pressure state, not a volume state, right? In
Yes.
hypertension, you have pressure overload, not volume overload. In any case of pressure overload, and when there is a what you can say hypertrophy of the heart, concentric hypertrophy, and the decrease in the chamber size because of too much pressure, you will find an extra S4 sound. S4. So whenever you see S4 written in the question, just get get an idea that they are talking about pressure overload, not volume overload.
Okay, 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 okay. So
Whenever
there,
they
then there you think about hypertension. Okay.
whenever they say S3 in the question, that you are appreciating S3, so it means they are talking about volume overload. This is a very big difference in the question. Sometimes the question is too difficult. You're not getting anything from the question. I have seen step 2 questions as well. Students are not getting anything, but this S3 and S4 tells the answer actually. If they say S3, always look for the option with increased volume. you know and if there is S4, just look for an option of increased pressures like hypertension or aortic stenosis or coarctation, blah blah blah. Are you getting me?
Yes, yes, yes.
Because of too much pressure, there can be aortic dissection as well, right? Aneurysm as well. The patient can even get a stroke because of so much hypertension, right? And this hypertension can cause hypertensive nephropathy as well. The kidney can fail because of too much pressure in it, right? And then
Yes.
eventually they get hypertensive retinopathy as well. So these are the complications that you can see in a patient with hypertension. So any question with the hypertension? Now you know everything that hypertension can do and present.
Yes, yes, yes. Makes sense.
On to the next topic. The next one in
Yeah.
front of you is the hyperlipidemia signs. Now, this is something which is clinical. If you read these signs very well now, and whenever you see a patient with this, you can immediately pick it up. It's very classical. You know,
Yeah.
in patient who has hyperlipidemia in them. Okay. Now, first of all, it's a biochemistry topic. Okay, there are so many types of hyperlipidemia, like type 1, type 2, type 3, type 4, type 5. In some time, there is LDL is increased. In another type, there is triglyceride is increased. In the third type, there is chylomicrons are increased. So different types and different sort of lipids increased. Okay,
Yeah.
in any of them, in all of them, the presentation is same like this. Okay, and then you check the lipid profile, then we'll come to know, okay, which type of lipid is increased, then you will treat them accordingly. So xanthoma, look, these are plaques or nodules which are composed of lipid laden histiocyte in the skin, and these will look like this. They are simply lipid deposition in your skin. When they are present at your eyelid, they are called Zennelis mass, like this. Look how
Mm-hmm.
classic they are. And they are so classical that you just see them and you diagnose them. So classical. And these xanthoma can also deposit around your tendons like this. Okay. and this is called tendinous adenoma. Simple. Okay. Now
Okay.
the same lipid can go and deposit around your cornea, and this is the cornea. Around the cornea, you can simply see this blue thing. Can you see that?
Yes, 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 yes,
This
yes.
blue thing around your cornea is called corneal arcus. Okay.
Mm-hmm, mm-hmm.
Corneal arc. It's a very important clue that the patient is having hypercholesterolemia. Usually, in normal individual, you see the corneal arteries in very late in elderly age, like above 70, above 75, because of in them the lipids are very bad. Okay, but you see
Yeah.
you see the corneal arteries in someone who is very young. I mean, who is some 20, 30, or 40. It means that he has underlying hyperlipidemia. You need to evaluate that patient. I mean, so this is the significance of seeing these pictures basically. Are you getting it?
Okay. Yes, yes, yes.
Okay, very good. Then comes your arteriolosclerosis. Remember, this is not atherosclerosis. This is your arteriolosclerosis. Arteriosclerosis. Can you see that?
Yes.
It means that arteriosclerosis, your arteries has sclerosed, hardened,
Yes.
hardening of the arteries. Okay.
Mm-hmm.
Now, the arteriolosclerosis is divided into two: arteriolo and monkey bird. What do you mean by arteriolo? Come on, come on,
I have
here.
no idea. I mean, I know it's arteries, but I don't know what they mean by arteriolos. Maybe more than
Arteriole
one.
is arterioles. Sclerosis of the smallest arteries, arterioles.
Okay, smaller arteries. Okay.
Okay, I mean the smallest arteries that you have are the arterioles, right? Before they
Yes.
differentiate into capillaries, we discussed the diagrams very well. Remember,
Yeah. Yes, yes, yes.
right? So arteriolosclerosis means the hardening of your smallest arterioles. Now, the hardening of these arterioles can occur by two reasons. There are two types. One is the hyaline type, and another one is the hyperplastic type.
Mm-hmm.
Okay, the hyaline type, okay, is seen in cases of hypertension or diabetes.
Okay.
Hyaline type is seen in cases of hypertension or diabetes, whereas the hyperplastic type, okay, in here you will see in the cases of severe hypertension only, in which smooth muscle proliferate around. See this diagram here, the B.
Mm-hmm, mm-hmm. I see.
See
Yes.
this smooth muscle with nuclei as well. Can you see that? And the lumen of the
Yes, yes.
artery, this is the hyperplastic. Whereas the hyaline, you can see this hyaline pinkish material.
Mm-hmm.
Okay, so the hyaline type and the hyperplastic type has these histological findings, that you can expect in the exam and you can answer them. Okay, so
Okay.
remember that hyaline subtype is associated with the hypertension or diabetes, and the hyperplastic subtype is associated, although with the hypertension, but it has got hyperplasia. Okay, one more thing.
So that's B, right? That's B. Hyperplasia. Sorry, hyperplastic.
The B is hyperplastic and A is the hyaline. Okay, one more thing
Yeah.
about hyaline. Hyaline, as I said, is associated with diabetes and non-malignant hypertension. Remember the difference. Hyaline is in non-malignant hypertension, whereas hyperplastic, you see this more in malignant hypertension.
Got it. Got it.
Okay, the hyaline type can do, glomerular scarring, and it can also cause chronic renal failure. Okay, on
Mm-hmm.
HNE staining, the hyaline will look pink. This is HNE stain, basically. This is pinkish material.
Got it.
As a hyperplastic dye, as I said, it's seen in malignant hypertension. Okay, here there is fibroid necrosis of blood vessel. Along with that, it is seen in acute renal failure. So hyperplastic type is seen in acute renal failure, and hyaline type can cause chronic renal failure. This is one huge difference.
Okay, 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 okay.
I mean, you just listen to the video again and write these points down, and then you'll get an idea.
So the chronic one is caused by the hyperplastic because it causes
No, no, no,
malignant
no, 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 you just make the wait. Let me summarize. Hyaline type associated with diabetes and non-malignant hypertension. Hyaline type can cause chronic renal failure. Hyaline type can be seen on as pink color on HNE staining. Okay, now let's talk about hyperplastic type.
Okay.
Hyperplastic type is seen in malignant hypertension because malignant hypertension is a very severe condition and it can cause end organ damage acutely. So that's why hyperplastic type can cause acute renal failure. You understand it now?
Oh, yeah, yeah, yeah. Makes sense. Makes sense now.
Okay, so hyperplastic type, because it's malignant, is causing acute renal failure. Hyaline type is chronic, so that's why it can cause chronic renal failure. Simple difference.
Got it. Got it.
Okay? Whatever it is doing, whatever the types are, just remember arteriolo, they are talking about the smallest of the arteries, the arterioles.
Okay.
Okay, then comes your Monckeberg sclerosis, medial calcific sclerosis. Do you know anything about it?
No, I don't know much about it. Instead of like saying it gets calcified, maybe
Yes,
because of
every
calcium.
each and every medium-sized vessel of the body has calcification in it,
Yeah.
and it does not obstruct the blood flow, and it does not put anything. Okay, so I mean you
It
can
just
say it's
okay.
just a age-related thing, yeah.
Okay.
Okay, but
Okay.
on the medium-sized vessel, you are your radial artery, femoral artery. These are your named all named arteries other than your large vessel are called medium-sized vessels, like femoral artery, okay, tibial artery. These are
Makes
all
sense.
your, and in this diagram they have shown you the femoral artery. Relax. Can you see the femur here?
Yes. 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 I see it. I see it.
Right? So remember that the medial calcific sclerosis, the monkeypox sclerosis, is not harming you. It's not harming the patient. It's not causing anything, any change to the blood pressure. Okay? So they are
Mm-hmm.
unless. So this is arterial.
So, so the marking work, the only way you will be able to identify is by looking at the picture that they give you. You have to see if it's
Exactly.
calcified. Okay.
Exactly. There is no other way.
Hmm.
Okay? Then
Yes.
comes your atherosclerosis. Now this is the atherosclerosis. That was arteriosclerosis.
Yes.
This is athero. Remember, athero comes from the word athroma. Here, we saw xanthomas. Remember? So,
Yes. Yes. Yes.
whenever say athroma or xanthoma, they are talking about lipids. Arteriosclerosis,
Oh, okay.
okay, arteriosclerosis was not associated with lipid things. It was associated with diabetes and hypertension only.
Mm-hmm.
When atherosclerosis, meaning that they are talking about lipid deposition in your vessels.
Makes sense.
Understand
Makes sense.
the beauty. Okay. So atherosclerosis means there's lipid being deposited in your blood vessels, okay, which is obstructing the blood flow then. Okay, simple. Right? Disease of the elastic arteries and large and medium-sized arteries, a form of arteriosclerosis caused by buildup of cholesterol plaque. Atherosclerosis is because of cholesterol plaque, right?
Yes.
The more the lipid you have, the more chances of getting an atherosclerosis, isn't that?
Yes.
Now, location, look at that. The most common site of developing the atherosclerosis is not actually the coronary artery. The first is abdominal aorta.
Mm-hmm.
Okay, the first is abdominal aorta. And where in the abdominal aorta? I mean, your abdominal aorta is too big. Where in the abdominal aorta you get this?
Oh, maybe the location where it's located
Yeah, location.
towards us.
They are talking about the location. Okay, let me tell you. Distal to the origin of renal artery up to the bifurcation of the aorta. This is the location of developing atherosclerotic plaque. Distal to the origin of your renal artery and up to the bifurcation.
Mm-hmm.
This is a site where the patient can get atherosclerosis. Now, understand the beauty now. So let me make your concept, because right now we are getting things very easy. This is the aorta, right?
Mm-hmm.
Suppose here are the renal arteries. I haven't built anything proximal to it. Okay,
Okay.
and as you know that the aorta will then bifurcate into the iliac artery, right? Common iliac artery, isn't
Yes.
that?
Yes. Yes.
And then
Yes.
common iliac artery will then further divide into two, isn't that?
Yeah.
The external iliac artery and the internal iliac artery like this,
Yes.
isn't that?
Yes.
Iliac. Now just imagine if you have a atherosclerotic plaque, let's make it in orange so that it really looks like a lipid. If you have
Mm-hmm.
atherosclerotic plaque somewhere here, okay, so what will happen?
Well, I mean, there's gonna be a decreased blood flow. Top. I mean, the bottom, lower
Very,
limb.
very good. Oh my God, good point. So you are trying to say that if someone has atherosclerosis here, okay, let's make it like this. So you are saying that whatever blood is in the aorta, decreased amount of it will go there, right? Because it behaves as an obstruction, right?
Yeah.
Yes, you are right. So the patient will get signs and symptoms of claudication. Very good.
Yes. True. Pain. They'll
Claudication,
have pain at the bottom. Oh God.
yeah, claudication means when the patient walks, because when he will exercise with his legs, he will feel pain.
Yeah.
Because if he cannot accommodate increased blood flow, because during exercise you need more flow, right? Because
Yes.
now there is atherosclerosis, decreased amount of blood is going to your arterial artery, right? So the patient
Yeah.
will have claudication, and when he rests, the pain will go. When we exercise, the pain will increase. This is a classical presentation, right?
Yes.
On the other hand, because low blood is going towards his, extremities, he will have loss of hair on his extremities. His skin will become too shiny. I mean, these are all reflection of hypoxia in the extremities. Okay.
Yes. Yes.
On the other hand, you can also see that the internal iliac artery is also getting decreased blood supply, right? And internal
Yes.
iliac artery supplies the pelvis, right? So the patient
Yes.
can also present with impotence. So it is a very important cause of impotence as well.
Sorry, they would develop. Sorry, what? Impotence? You said?
Yeah, yeah, impotence. Yeah.
Okay.
Okay, so I mean, this is the cause. I mean, this is the most common location of developing atherosclerosis in the sign and symptom the patient can guess. Okay, the claudication, the impotence. Now you understand why elderly patient can develop a claudication or impotence. Okay, so one case dismissed. Let's go to the first
Yes.
again. Right. So the common location abdominal aorta. The second common location is the coronary artery. Now, coronary artery. When the atherosclerosis involves the coronary artery, simply the patient will present with angina.
That makes sense.
Right, angina, simple. So if the
Yeah.
angina is so severe and involves all the heart vessels, I mean the atherosclerosis involves all the heart vessels, okay, the right coronary as well as the left coronary, then the patient will develop an MI, I mean severe MI. For that, the patient you need to do a cabbage, and if MI is because of only one vessel, you need to do a PCI,
Yeah.
right? And the third place where the patient can get this atherosclerosis is the popliteal artery, then the carotid artery. So these are the locations, okay? Just remember from most common to the least common one, okay?
Okay.
And when it involves the carotid artery, can you tell me what will be the presentation of the patient?
Carotid arteries.
Trans
Oh. Yeah. 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 The heart block.
no, 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 no.
So.
Yeah, no, no, no. It's not compressing from outside. Heart block will be there when you compress the carotid from outside and when you stretch those fibers, right? When you increase the
Yes.
activity. This atherosclerosis is inside the vessel. Okay, it's not stretching it. So
So then.
when yeah, the presentation is actually TIA, transient ischemic attack. Transient ischemic attack means transiently the blood flow of the brain becomes too low. The patient will be present with a sign and symptom of ischemia of the brain, ischemic stroke. And when the
Mm,
ischemia subsides, the patient, the stroke will subside. So TIA means the transient stroke presentation, which is resolved within 24 hours.
okay.
Okay, I think you haven't heard about it before.
No, I have heard about the ischemic stroke, but I wasn't sure carotid artery is the reason behind it.
No, 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 no.
Uh,
I am not saying carotid artery is the reason behind ischemic stroke. I am saying transient ischemic stroke, TIA.
yeah, I heard about the ischemic stroke. Yeah, maybe you're right.
Okay.
Yeah.
Look, transient ischemic stroke means presentation of a stroke that resolves and completely go away within 24 hours. This is called TIA, transient ischemic stroke.
Okay, got it.
Okay, why? Because when you have carotid artery atherosclerosis, I'm going to need high amount of blood. Sometimes because of low amount of blood coming from the atherosclerotic vessel, the patient get ischemic stroke transiently, and when the blood flow restores, that goes away. Okay, so this is called transient ischemic stroke.
Got it. Got it.
For
Got it.
transient ischemic stroke, you need to do the ultrasound Doppler of the carotid arteries.
Okay.
So these are locations of the atherosclerosis. The risk factors are same. The modifiable, smoking, hypertension, dyslipidemia, diabetes. Right? These are things that you can modify. I mean, you can ask the patient to quit smoking, you can treat the hypertension, you can treat the lipidemia, you can treat the diabetes. And there are certain
Okay.
non-modifiable, certain like age. You cannot modify the age of the patient. You cannot modify the sex of the patient. Look, atherosclerosis is seen more in the males and in post-menopausal women. In pre-menopausal women, estrogen is protecting them, right?
Okay. Yes.
Estrogen prevents hyperlipidemia in premenopausal women. That's why risk of stroke is risk of and heart attack is too low in premenopausal women. That's why more males die of heart attack than the females because estrogen protects the female.
Got it. Got it.
Also, the family history.
Okay.
So, you can ask me, where is obesity?
Well, yeah. I mean, with diabetes,
No, no,
obesity could be there.
no. Diabetes and obesity are different things. Someone who is very thin and lean can get a type 1 diabetes.
Yeah, that's true too.
So why they haven't talked about obesity? I mean, look, now you will say dyslipidemia. No, dyslipidemia can be congenital and dyslipidemia can be in someone who eats too much lipid. I'm talking about why they haven't separately mentioned obesity. You know why? Because
Because maybe you can control
no,
that with exercise. Maybe
no,
that's why they did.
if it was controllable, then they would have written in the modifiable, isn't that?
Okay. Yeah.
The reason is that, because obesity is debatable. Why? On one side, you can say that obese patient has too much lipid, which can cause atherosclerosis. Yes. On the other side, obese patient has an enzyme which converts the testosterone into estrogen, and estrogen prevents the development of atherosclerosis and MI in them.
But that's in both men and women?
Yes, obese men and women, in both of them. I mean, women already have estrogen, but when they are obese as well, they will produce more estrogen because the fat cells has an enzyme. I think the name is aromatase, which converts the androgen into estrogens, the estrone form.
Yeah, yeah. It is aromatase. That's the one that converts it. Yeah. Okay.
Okay, this is the thing. This is the reason behind that. Okay, that's why they haven't mentioned it separately. They are too smart. They will not mention anything that is controversial because it will go against them.
Okay. Okay.
Okay, so obesity has both extremes. On one side, it can cause atherosclerosis because of lipids in them. On the other hand, it opposes the atherosclerosis because of the estrogen being produced. Okay, so you should know the
Right.
reason. Right? Maybe they can give you an experimental question and ask you. Maybe you can do some work on it. Anyways, so symptom obviously will be angina, claudication, but sometimes can be asymptomatic. Yes, most of the time these patients remain asymptomatic until and unless the vessel diameter gets too narrow. Isn't that?
Mm-hmm.
I mean, for example, if you have a patent vessel which is, through which the 100% of the blood is going, now because of atherosclerosis, in the beginning of the atherosclerosis, 90% is going, then 80%, then 70, 60, 50, until you become symptomatic. Are you getting me? So that's why
Okay.
the patient,
Okay. Go
hello,
ahead. Go ahead. Go ahead. No,
yeah.
no.
So that
Finish it off, and then I'll ask you after. Yeah.
this is the reason, the patient remains symptomatic for a long time until the diameter of the vessel becomes so narrow that they will present with symptoms. Now, progression. This is the most important thing that you should be aware of, and this is most difficult now. First, let's read it from first state, and then I will discuss. Look,
Okay.
inflammation is important in the pathogenesis. How? Endothelial cell dysfunction, macrophage and LDL accumulation, form cell formation, fatty streak, smooth muscle migration, proliferation, extracellular matrix depletion, fibrous plaque, complex atheroma. What the hell is this? Are you getting anything from it?
Well, I mean, somewhat, because you see all these things happening now. There. Um.
Okay, let's draw it.
Yeah.
This is a wonderful diagram. I like this diagram.
You're actually a good drawer, and you explain well too.
Thank you. All right.
Yeah.
So let's suppose this is a blood vessel, right? Any blood
Yeah.
vessel. And in this blood vessel, you have got your endothelial cells like this. These are your endothelial cells.
Yeah.
Okay. On both the side of your blood vessels, you have got endothelial cells. Remember, endothelial cells are the cells of the blood vessel. Okay. And
Yeah.
in the blood vessel, you have your cells, traveling freely, the RBC, the macrophages, the WBC, cells are traveling like this.
Mhm.
Okay. This is a normal blood vessel right now. Now,
Okay.
atherosclerosis means the first thing there is endothelial cell dysfunction. Let's take this cell. There's
Okay.
problem with this cell. Okay. This cell is has some dysfunction. Now the question is why it will get dysfunction, because the patient has too much lipid in his blood, has got too much LDL, has too much triglyceride, whatever lipid it is, right?
Yes.
Okay, and it keeps on irritating the endothelial cell. So endothelial cell will ultimately get and dysfunction, right? Now
Mhm.
what will happen, macrophages are usually, these LDL and lipid usually travel inside your macrophages. So the macrophages will take these lipid inside these endothelial cells. Inside, okay?
Okay.
Let's take the cell outside and draw this only. So suppose this is
Okay.
your endothelial cell that was drawn. Okay.
Yes.
Now a macrophage filled with LDL is now inside. Okay. It
Yes.
brings the LDL inside. Okay.
Mm-hmm.
Below your endothelial cell are smooth vessels as well here, like this, arranged like this.
Mm-hmm.
There are smooth muscles as well, and there are connective tissue as well, and the adventitia of the blood vessel, right? So your blood vessel is arranged like this: intima, media, adventitia. Intima means endothelial layer, media means the smooth muscle layer, and adventitia means the connective tissue layer of the vessel. So
Okay.
once again, any blood vessel in the body has intima. Intima is the endothelial layer. Media means the smooth muscle layer, okay, and
Mm-hmm.
then adventitia is the connective tissue layer of the blood vessel, right?
Yes.
Are you getting it? Okay.
Yes. Yes.
So
Yes.
what happens is your LDL along with the triglyceride, okay? Oh, sorry, along with the macrophage, they went inside your endothelial cell, right? Because of the endothelial dysfunction. Now, when it goes inside, the macrophage engulfs it, all the LDL that's present, and it becomes a foam cell.
Okay.
What it becomes? It becomes a
A
foam cell.
foam cell. Yeah.
So too many foam cell will then accumulate inside. Too many foam cell will accumulate here in your endothelial cell, right? So it will be
Yes.
filled, it will be full of foam cells then. Now these foam cells will release some chemotactic factors. It will release some cytokines as well, which will ask the smooth muscle cell below. Remember the media is below the endothelium. So the
Mm-hmm.
muscle cell will then migrate, will also migrate inside the endothelium. Okay. So now the
Yes.
smooth muscles are also here. So now you have got foam cell as well as the smooth muscle. The smooth muscle will release the platelet derived growth factor and then the FGS as well. Okay, the platelet derived growth factor and the fibroblast growth factor will increase the size of this endothelial cell. So
Okay.
it means that now it's growing. Why? It has to grow because there are so much foam cell as well as there are so much smooth muscle cell, right? So it will
Yes.
keep growing like this. Okay, remember the smooth muscle cell are releasing the PDGF and FGF. PDGF, it is the same PDGF that was causing clubbing.
So platelet-derived growth factor, and what's another one? Fibroblast growth factor. Okay.
Yeah, it means that these things can increase the tissue size like it did in the nails, right? So simply it is
Yes.
doing endothelial cell as well. So what is happening? So you form foam cell and the smooth muscle cell also came inside it, okay, and it keep on growing, and this thing is called now a fibrous plaque.
Because it became bigger now. Okay.
Yeah,
Okay.
it's a fibrous plaque. It's a plaque, isn't that? And
Yes.
ultimately, after some time, it will become a complex atheroma after becoming so big. So
Mm-hmm.
remember, this is happening on both sides because there are lipids in the blood vessel, right? This is happening on
Yes.
both, and that's why the blood flow is decreasing. This will lead to atherosclerosis if it fully, increase in size. Remember that these two will never cause complete obstruction. They have no ability to cause 100% obstruction. Okay. So thing is that you will never get an MI until the plaque is stable. Until the cap, this cap, the fibrous cap that you have formed,
Yes.
until it is stable, you will never get an MI. Problem arise, the patient will get an MI when this is ruptured because of any reason. When it get ruptures, then it will completely obstruct it like this. Okay.
Oh,
So
if
remember,
the cap is obstructed, then they will join. They will call
no,
an obstruction.
if the cap ruptures, look, until the
Okay.
cap is stable, until and unless the cap is stable, there will be no complete obstruction, and the patient will be having angina only. Once the
Okay.
cap ruptures, the patient will develop an MI.
Ah, makes sense. Makes sense.
Okay, so this is the thing. So stability of the fibrous plaque actually determines the development of MI.
Okay. Okay.
Okay, so this is the thing. And how will you prevent the rupture of this plaque? You will give the patient drugs like aspirin. You will give the patient statins. This will prevent the rupture of this plaque.
Okay. 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 Makes
Okay,
sense.
that
Makes
is why
sense.
people who are atherosclerosis, they are always given aspirin. Aspirin is a
Okay.
blood
Makes.
thinner. Aspirin is a blood thinner. It will not allow the blood to rub against this fibrous cap and rupture it.
It will prevent it from thickening it up. Okay.
Yes. Okay, so understand why you are giving, and also you are giving the statins. The statins are what? Anti-lipid drugs to
Yes,
prevent
yes.
the increase in size. So I hope you now
True, true.
understand the pathophysiology here.
Oh yeah, yeah, yeah. Makes much more sense.
Very good. Okay, so we need to stop here and we will resume from here. You can see the
Okay,
time.
sorry. Yeah, yeah, yeah. I just had a question about the modifiers. um, and that's what I was gonna ask you before, but then you move on to the next one. I just want so modifiers that you explained, they are just what causes what can cause
No, no.
atherosclerosis.
Modifiable risk factors means you can treat them like smoking. You can quit smoking anytime. You can treat the hypertension. You can treat the hyperlipidemia. You can treat the diabetes. Non-modifiable means it's not in your hand. You cannot treat it. Age, sex, family history. It's always there.
Oh, okay, okay. Because I was thinking they mean like these. If you do not treat these, then they can lead to
No, no, no.
at.
Risk factors means they increase the chances of getting the atherosclerosis.
Got it, got it, got it, got it. That
The
was
more
my only.
the more the risk factors you have, the more atherosclerosis will you get. The lesser the number of risk factors, there will be lesser chance of getting atherosclerosis. Okay, we'll
Got it. That was
from
my
here,
question.
don't worry about it. We'll resume it from here and we'll resume from the same picture. Let me save this for you. Okay.
Yeah, yeah, save it. So we'll continue. It's a really good picture. Next week, I'm going. So I should reach early morning on Monday around 5. So if you want, you can schedule me towards the end of the week instead of beginning.
Okay. Which days? End of the week means which days? Like,
It could be any days is fine because I can do weekends now too, right? So it doesn't matter. I mean, you can start maybe from Thursday if you like. Thursday,
okay.
Wednesday, Saturday,
Yeah.
whatever, Friday,
Okay. I said,
whatever. Yeah.
no. Okay.
Yeah, okay. All right. See you. Thank you. Bye.
Pleasure.
Bye.